So again, just to bring us back to the social technical systems approach. So what does it tell us? It tells pay attention to both technical and social work systems. So in general, I think, that was already mentioned. So create a system that is more collaborative and integrative. But how do we achieve that? I guess is like one of the questions. Bring together previously clinical expertise and laboratory capabilities. Also mentioned. So that would sort of also include the social work system. And so what they've done, they have sort of implemented regular expert panel meetings. Those didn't happen before. So these panel meetings, they were sort of specialists, sort of pediatricians and lab scientists, to all have comprehensive in-depth discussions of undiagnosed patients, and they collaboratively work towards a diagnosis. What really is striking about these panel meetings is that often they sit there and specialists talk about things and others may not necessarily understand what's going on. So there was a very high level of psychological safety that the program designers were well aware of, sort of saying, there are no dumb questions, or really like make a comment, because sometimes people would start talking about things and they would almost need to be educated about it. But that also had impacted on their own work design, because after implementing this, you can see how they were learning about things that they would usually not have access to. So that was, again, also something that would draw people into it, because they were saying there were a lot of geneticists talking about things that were quickly developing, and that from technology aspect, sort of genetic testing has been changed dramatically in the last 5 to 10 years. And a lot of clinicians, they couldn't really be on track on what's going on. But within those meetings, they would learn sort of about new tests and new databases that would help them to sort of get down to a problem. What they also introduced was an online knowledge platform. So that would be more technology aspect, but you can see how the technology here and the social work system, they have to be designed together. So you can't just introduce a technology without using it or without helping like people using it. So it was called the patient archive. And that was used to manage the scientific and patient related information. And it did help in streamlining that diagnostic process, which was crazy. Like there were really piles of patient data, and they would sort of put that into that. Another aspect that helped with the technology here was that the technology could sort of parse or go through it, and there was an algorithm that could sometimes give a guess about what was going on, even though a lot of the clinicians that we interviewed, they were saying many often this AI or artificial intelligence wasn't really giving good, so that there was never something useful in it, but it would help them in sort of coming up with more ideas. But it was a way to motivate people to sort of copy in this information. And lastly, I guess that was also key in this change is they introduced a nurse coordinator, which did help a lot with the admin support. And she was mentioned in quite a lot of interviews. She would sort of collate the data, put them in the system, things that many of the doctors wouldn't have time for. She would also help in organizing the meetings and things like that, because these clinicians, they were all like short on time. And I do want to mention that these expert panel meetings, they did them over their lunch break. So this is something where you can see how there is a bit of organizational resistance to sort of make it really formally implement that. And you can see that there are some informal elements that are driven by the proactivity, by the clinicians who are involved, that really saw a value in implementing this. So it sees again, like we drew sort of the redesign system where you can see how the expert panel meetings, they helped in linking the information flow. And that was something that was so key, because like the delay that was mentioned by many clinicians, that when the sort of patient was moving through these different departments and hospitals, and they wouldn't get any feedback because this department wouldn't speak to the research lab and so forth, or like there wasn't really like an interactive element. You could see really come that to life in the panel meetings when they would discuss a patient, and they would have almost like these eureka moments. Sometimes they would go, oh, okay, this is what the test means, and this is how they would link it. So that was a key element in implementing this change. And you can also see how the nurse coordinator sort of would collate the different test information here, and they could draw on a external network that also had access to these databases of the patient. So what we did is we linked that to the smart model. So we sort of shadowed this change. This wasn't the change that was implemented by us. There was a change that was really implemented by a program in the health system, and we just analyzed it. But you can link that quite neatly to the smart model, which we have done. So here again, this is some of the original quotes from the people that we interviewed, and how they reflected on this after this formal redesign. And so they were saying is you just learn by being there. I think it's such a good learning experience and so interesting. And we got that a lot. A lot of the clinicians said after that, there was really a motivation just to go there because there was a lot that they couldn't catch up with because it was something that they have done in their studies, but because of medicine and genetics was just evolving so quickly, it was really for them and a way to sort of be on track with what's going on. Same with mastery. So feedback was mentioned a lot of times. This is one of the biochemists who played a key role in the program, saying feedback were critical. Otherwise, like any human day, if you're banging your head against the wall, it's always nice to know that there was some reason for it. And they would also say that, that the delay in getting feedback was much more reduced, and that gives them meaning. And they could also, through the expert panel meetings, they could see the whole patient. Whereas before they've only seen a body part only, they would see how different systems are linked together, and they would see how some of their efforts would have an impact not only on the patient, but the family and some even other patients who were sitting in a different part of the world, having a similar case, and they could link them together. So that was really nice. I'm skipping over agencies here because they already had quite a lot of agency, except maybe for the bureaucratic hurdles that they were all sort of reporting on in their job within the hospital. But as we already pointed out, the relational aspect was elevated. So here the clinician is saying, so the collective real-time thinking and investigating is the thing that gives it life. And that was something that a lot of them mentioned, that the stimulation was actually something that really draw them into the program and participate in the panel meetings. And the demands were reduced through the redesign. So one of the quotes here from the clinicians is, one of those cases has been weighing on my shoulders for years, and going through the program, it was sort of solved. I do have to say though that sort of the knowledge processing demands that were already quite high, but it was probably the nurse coordinator and the collective effort that reduced some of the demands of these clinicians. So this is why I linked the socio-technical systems approach to almost all the letters of the SMART model, because that's a really good example of how it can be effective.